Hello, friends. Today, we're taking a deep dive into multiple sclerosis, often called MS, a chronic progressive autoimmune condition that affects the central nervous system. Our goal isn't just to define it. We'll explore what's actually happening at the cellular level, why it plays out so differently from person to person, and the four key patterns of how this disease can progress over time. Let's begin with the basics. The central nervous system, which includes the brain and spinal cord. What exactly is MS attacking in there? The main target is myelin. Think of it like the insulation around electrical wires. It's a fatty sheath surrounding the axons, or nerve fibers, that ensures nerve signals travel quickly and efficiently. This myelin is produced by special cells called oligodendrocytes. In MS, the body's immune system mistakenly attacks these oligodendrocytes and the myelin they produce. It's a huge error. The immune system turns against its own tissue. When that insulation is stripped away, nerve communication breaks down. Signals either slow dramatically or fail to get through at all. That leads to the wide variety of problems seen in MS, from motor difficulties to sensory and even cognitive issues. Now, how does this attack actually start? The brain has a strong defense system called the blood-brain barrier, or BBB, which normally keeps immune cells out. So how do the main culprits, T cells, get past it? They need the right molecular credentials. Certain molecules on their surface act like VIP passes, allowing them to interact with the cells of the BBB and cross into the brain. A few T cells sneak in this way, but once inside, the real trouble begins. When one of these T cells encounters myelin, the very thing it's not supposed to attack, it becomes activated. That activation changes everything. The T cell causes cells of the BBB to express more receptors, opening the door for even more immune cells to flood into the brain and spinal cord. It's been described as bribing the bouncer. Once the door is open, a full-blown inflammatory response erupts. This is a classic type 4 hypersensitivity reaction, a cell-mediated immune attack. The activated myelin-specific T cells begin releasing inflammatory chemicals called cytokines, including interleukin-1, interleukin-6, tumor necrosis factor alpha, and interferon gamma. These cytokines do two major things. First, they make the local blood vessels leaky, allowing even more immune cells to pour in. Second, they directly damage the oligodendrocytes, those myelin-producing cells we mentioned earlier. But the T cells don't act alone. Their cytokines act like distress flares, attracting other immune cells, B cells and macrophages. The B cells start producing antibodies that stick to myelin proteins, effectively tagging them for destruction. Then macrophages, the cleanup or demolition crew of the immune system, recognize those antibody markers and engulf the myelin and oligodendrocytes. So T cells damage, B cells mark, and macrophages destroy. The result is loss of myelin and death of oligodendrocytes, leaving behind scarred areas known as plaques or scleroses. And that's where the name multiple sclerosis, meaning many scars, comes from. Without myelin, nerve conduction is disrupted and normal neurological function is lost. Now, MS is famous for its relapses and remissions. If damage occurs, how can the body sometimes seem to recover, at least temporarily? Early in the disease, the body has two ways to calm the attack. First, regulatory T cells, the immune system's brake pedals, move in to suppress inflammation and restore some balance. Second, the surviving oligodendrocytes, or newly formed ones, can attempt to repair the damage by rewrapping axons with fresh myelin, a process called remyelination. This explains the remitting phase of relapsing-remitting MS. But over time, repeated immune attacks destroy more oligodendrocytes, and the ability to remyelinate declines. Eventually, the axons themselves degenerate, leading to permanent and progressive disability. So, what actually causes MS? It most often appears between ages 20 and 40. The exact cause remains unclear, but it's thought to be a combination of genetic susceptibility and environmental triggers. Genetically, women are more frequently affected, and there's a strong link to certain immune system genes, particularly HLA-DR2. HLA molecules normally help the immune system distinguish self from non-self. But in people with the HLA-DR2 variant, this process goes wrong. The immune system mistakenly presents parts of the body's own myelin as if it were foreign, setting up a lifelong case of mistaken identity. Environmentally, vitamin D deficiency plays a major role. MS is more common in regions farther from the equator, where sunlight exposure, and therefore vitamin D production, is lower. Certain viral infections may also act as triggers. Together, these factors may create the perfect storm in which autoreactive T cells aren't properly eliminated or controlled. Now let's look at how MS progresses. There are four main clinical patterns, best visualized as lines on a graph showing disability over time. The first and most common type is relapsing remitting MS. Here, patients experience distinct attacks or relapses, periods of new or worsening symptoms, followed by partial or full recovery. Between relapses, disability levels often remain stable for a time. The second type is primary progressive MS, PPMS, where disability steadily worsens from the very beginning without clear relapses or remissions. The progression is slow but continuous. The third type is secondary progressive MS, SPMS. It begins like RRMS, with relapses and remissions, but eventually transitions into a progressive phase where disability worsens steadily even between attacks. Finally, the rarest form is progressive relapsing MS, PRMS. It combines steady progression from the start with superimposed acute relapses, making the decline faster and more severe. The symptoms of MS depend entirely on where plaques form within the brain or spinal cord. A lesion in one area may cause visual problems, while another may cause weakness, numbness, or imbalance. Symptoms often develop over days to weeks and may last for months if untreated. One classic pattern of MS involves Charcot's neurological triad: dysarthria, slurred speech, nystagmus, rapid involuntary eye movements, and intention tremor, shakiness that worsens when trying to perform a task. Optic neuritis, caused by inflammation of the optic nerve, is another hallmark. It can lead to blurred or dim vision, color desaturation, pain with eye movement, or even central visual loss. Sensory disturbances such as numbness, tingling, or pins and needles are frequent. A classic sign called Lermit sign, an electric shock-like sensation down the spine when bending the neck forward, often indicates a plaque in the cervical spinal cord. Motor symptoms can include weakness, stiffness, spasms, balance problems, or even paralysis. Autonomic symptoms such as bladder, bowel, or sexual dysfunction can occur. Cognitive issues, difficulties with memory, attention, and processing speed, and mood changes like depression or anxiety are also common. Diagnosing MS requires evidence of lesions that are separated in both space and time, meaning different areas of the CNS affected at different times. MRI plays a central role by revealing white matter plaques in the brain and spinal cord. A lumbar puncture can detect oligoclonal bands, antibodies found in the cerebrospinal fluid but not in the blood, confirming an immune process within the CNS. Visual evoked potentials can also be used to detect slowed conduction along the optic pathways, another sign of demyelination. There's no cure for MS yet, but treatments have advanced significantly, especially for the relapsing forms. Management focuses on two things: treating acute relapses and modifying the long-term disease course. During a relapse, the goal is to quickly reduce inflammation. High-dose corticosteroids are the mainstay, as they dampen the immune response. If steroids are ineffective or contraindicated, other immunosuppressants like cyclophosphamide or procedures like plasma exchange may be used to remove harmful antibodies from the blood. For long-term control, disease-modifying therapies, or DMTs, are used to reduce relapse frequency and slow progression. Drugs such as interferon beta decrease inflammatory cytokines and boost regulatory T-cell activity, strengthening the body's natural braking system. Other medications work by preventing T-cells from crossing the blood-brain barrier in the first place. These strategies help protect the brain from ongoing immune attack. Progressive forms of MS are harder to treat since they involve slower neurodegeneration rather than just acute inflammation. Current DMTs are less effective here, so management often focuses on symptom control. Physiotherapy for mobility, medications for spasticity or bladder issues, and cognitive rehabilitation. Researchers are actively exploring newer therapies, including vitamin D optimization and approaches that might target the degenerative aspects of MS more effectively. In summary, MS is a complex autoimmune disease in which T cells breach the brain's defenses, attack myelin and oligodendrocytes, and leave behind scarred plaques that disrupt nerve conduction. The disease may come in relapses and remissions or progress steadily depending on the subtype. And as we understand more about immune regulation, one exciting area of research focuses on the body's own braking system, those regulatory T cells. Some treatments, like interferon beta, already enhance their effect. But imagine if future therapies could supercharge these regulatory cells, stopping the autoimmune attack before it even begins. That might be the path toward truly halting or even curing multiple sclerosis someday.
Hi there, forest friend. Thanks for clicking on our video. We're so happy you're here. Before we jump in, don't forget to like, subscribe, and share this video with your friends.